Dr. Bindu, are you ready?
Yes, sir.
Okay, go ahead.
Okay. 50 years old lady with complaints of swelling in front of the
Okay,
neck,
before
which is
you start, have you done a case of thyroid in your training so far?
yes, sir.
Okay, good. Okay, then go ahead. A 28-year-old, go ahead. No, the mic is not on. Please unmute your mic and
Sir, could you hear me?
yeah, I could hear you.
Yes, sir. Okay, I'll start from the start, sir. 50 years old lady complains of swelling in front of neck, which is progressively increasing in size, causing dysphagia and dysphonia while lying on her back. History of presenting illness. Patient is apparently normal before 5 years, after which she developed small swelling in front of the neck, which is insidious in onset and gradually progressed and increased in size, associated with difficulty in swallowing. And the patient also complains of dyspnea on lying down position. We have to ask for any history of pain over the swelling, any history of recurrent fever, any history of URI. Is there any history of sudden increase in size or hemoptysis, history of any loss of weight or weight gain, history of any intolerance to heat or cold, history of constipation or diarrhea, any history of tremor, anxiety, fatigability, palpitation, or any history of voice change. Coming to the past history, we have to ask about the patient has any known comorbidities of diabetes, hypertension, bronchial asthma, coronary artery disease, CKD, epilepsy. We will need to ask about the drug allergy history also, history of any previous hospitalization, any history of previous surgery, or any history of radiation in the past. Treatment history is the patient is on any regular medications or not. Family history, is there any history of thyroid disorder running in the family, any history of malignancy in the family. Personal history, we need to ask about the diet pattern, bowel and bladder habits, and sleep pattern of the patient. Menstrual history, we need to ask about the whether the patient has a regular or irregular cycles, any history of amenorrhea, polymenorrhea, or menorrhagia. Coming to the general physical examination, on examination, a patient is conscious, oriented, moderately built and nourished. We have to check for height and weight and classify according to the BMI. We have to see for pallor, icterus, cyanosis, clubbing, lymphadenopathy, or any pedal edema. We have to also check for the skin, how it is, any moist or warm. Uh, we also need to check for the eye signs like lid lag, starry eye sign, or any inability to converge the eyes. And the general vital examination, which includes temperature, blood pressure, pulse rate, and respiratory rate. Coming to the airway examination, we need to check for a dentition, any gross facial dysmorphism, adequate mouth opening, is there any neck movements restrictions, is the tongue is able to be protruded, is the bilateral nasal cavity is patent. Coming to the thyroid examination, the patient is examined in the sitting position. Uh, both the hands are clasped and head thrust back against the occiput is given, and we examine the swelling regarding its position, nature of the swelling, size, shape, and skin over the swelling, whether it's moving with the deglutination or not, and we are able to check for the lower border of the swelling is appreciable or not. Coming to the palpitation, all inspectory findings are confirmed here. We check for the we palpate the swelling for the surface, consistency, skin fixation, is a trachea in position, is it deviated or not, and we also check for carotid brewing over the neck. Percussion will percuss over the sternal notch and notice whether it is a resonant or dull note. If it is dull note, it is the thyroid has invaded into the mediastinum as retrosternal goiter, and we also auscultate for any brewing over the thyroid swelling. Diagnosis, a 50 years old female presented with swelling in front of the neck with pressure symptoms and tracheal deviation with no retrosternal extension without hypo or hyperparathyroidism features with known comorbidities posted for excision of swelling.
Very
Probably
good.
a thyroid swelling.
Thyroid swelling. Okay. What are the other differential diagnosis for midline neck swelling?
In front of neck swelling, uh, any lymph node enlargement, sir,
Hmm.
laryngocele,
Hmm.
and in children it would be cystic hygroma.
Very good.
And
What is thyroglossal cyst?
sir, it's thyroglossal cyst is the remnant of the thyroglossal duct, sir. It would be moving along with the protrusion of tongue, sir.
So how do you confirm that and say that it is only a thyroid swelling? Which particular examination proves that it is a thyroid swelling?
Whether it's
To rule
moved,
out the lymph node swelling or to
whether it's
differentiate.
moved with deglutination or
Move is deglutition. Very good. What is the reason for it thyroid to move with the deglutition?
it's due to the suspensory ligament of Berry, sir. The pretracheal ligament which attaches the thyroid with the cricoid cartilage. And
Okay. So how do you do that? You just ask the patient to swallow the saliva, or do you do?
no, sir, we'll ask them to have some sip of water.
Hmm. So
And
what are all the things that you require before you start examining a thyroid patient? What are the equipments or accessories that you require before you start the examination? You said you want to make the patient swallow, so you require a glass of water.
yes, sir.
You said you will auscultate for bruit. For that, what do you
We need
require? A
stethoscope.
stethoscope. Do you require a knee hammer for examination of a thyroid patient? Have you been using knee hammer as a UG patient student?
Now we are not using.
What is the use of knee hammer? How do you use it?
So for reflexes, we'll use knee
Deep
gap
tendon reflexes elicitation. So can that be tested? That will require testing in condition of thyroid?
in mixed edema patient.
Ah.
Petal.
Hmm. What is pseudo hypertrophic reflex of the calf muscle? Edema. Okay, there will be a slow release after you do the Achilles tendon tapping. It will not
Yes,
be
sir.
a immediate jerk. It will lift up dorsiflexion will happen and get slowly released. Okay, so that is a confirmatory evidence of edema. For that you require. Will you require when the patient has a very fine tremor? Will you make out the tremor?
So we'll
How
ask the
to test for
patient.
tremor?
We ask the patient to extend both his arms
Ah.
straight, and we'll place a paper over the
Okay. What should be
hands.
should the patient remain eyes open or closed eyes? Is it important to ask the patient to close the eyes, or can they keep the eyes open?
We ask them to close the eyes.
Why?
Patient will be anxious. For normal patient,
Not only
will be
anxious, he can manipulate the hand. In case he is keeping the eyes open, a very, very fine tremor, he can try to control it by keeping his fingers very tight. Okay, but once they close the eye, they will not be able to have that control. So fine tremor can be judged by that, by placing a piece of paper or a sheet of paper over the outstretched fingers in the arm, the patient eye closed. Okay. So this is right. So your description always for a thyroid swelling should include whether it is been deviating the trachea, whether there is a retrosternal extension, whether the patient has got any hyper or hypo features. Now you said if the patient is looking like a euthyroid patient, there is no retrosternal extension, but there is a possibility of deviation of the trachea. So what
Yes.
important pre-anesthetic assessment you have to make in this patient?
We'll check for the tracheal position, sir, and that Couch's test will be positive.
What is that test? You push the gland from one side to the other and they do something?
Yes, sir. Towards the deviated side, the patient will develop dyspnea, like stridor kind of things, sir. When we push to the opposite side.
Okay. What are the objective investigations you can do to find out the tracheal deviation and compression?
We'll ask for X-ray neck AP and lateral, sir. Nowadays, they have started doing CT and MRI for the tracheal diameter and deviation and also.
Okay. Anything much more simpler than that at the bedside?
Trials, that would be.
You use that equipment for everything from head to toe nowadays. Blocks, central line access, radial artery cannulation.
Ultrasound.
Ultrasound. Okay. So ultrasound has a very important role in assessing the tracheal deviation and compression also. Airway assessment of ultrasound itself is a big topic. Okay. So
Yes.
remember that, which is much more simpler than doing more expensive studies like MRI and CT. Right. Supposing patient has a deviation and compression because of this huge gland, which is indicated by clinical evidence of patient finding it difficult to swallow and lie on her back. How will you proceed to anesthetize this patient?
So, we have to confirm about we have to do all pre-anesthetic checkup, like investigations and all would be done, sir.
Okay.
And everything after finding out the tracheal deviation, diameter, everything, will go for an awake fibro-optic intubation for this patient, sir. Since we don't know whether there is this is long-standing goiter, so there would be tracheomalacia. So when we induce the patient the airway may collapse, sir. So we'll do an awake fibro-optic intubation for this patient, sir, and we'll prepare accordingly, sir.
So will you push the tube beyond the compression or will it be kept above the compression?
Beyond the compression, sir.
Beyond the compression. Okay, so you should try to pass the tube beyond the compression so that it doesn't collapse at the level of compression. That will act like a scaffolding in doing that. Right. Once you finish excision, how do you know whether it is safe to extubate the patient? Because as you said, that is a long-standing goiter, there may be tracheomalacia. What do you mean by tracheomalacia?
It's a softening of the tracheal cartilages.
Cartilages, very good. So, how do you know that the patient will not go in for tracheomalacia before extubation?
We'll do a leak test for that, sir.
Fantastic, very good. So, what do you mean by leak test? How do you do
that? So, while keeping the ET tube in position, we'll deflate the cuff, sir, and we'll check for leak by assessing the tidal volume as well as by auscultating, sir. If you could find leak, it is positive. That is there is an air entry around the tube. But when there is no leak, there is no air entry around the tube. That signifies where there would be edema or any collapse of the trachea over the area, sir.
Very good, very good. So, in statistics, what important pre-anesthetic counseling you have to do with these patients like long-standing goiter with compression features? What precaution or pre-anesthetic counseling? What is the important thing that you have to tell the patient?
That we may do an tracheostomy as an emergency procedure in the operation table itself, sir.
Yes. Let's get a consent for tracheostomy also. That is very, very, very important. because several times patients have not been told, and you will end up with the problem of hypomalacia, where a patient will require an emergency tracheostomy or front of neck access. So you have to inform the patient of that possibility and get a consent also. Very, very important. Now, you said you have anesthetized the case of thyroid, and where will you start the IV line in this case? Thyroid surgery.
We have done IV lines in the upper arm only, sir.
Upper
And
arm,
here.
I mean the above the elbow. Did you start it in the cubital fossa for your case?
No, sir. We did a IV line over the dorsum.
Dorsum of the hand only. But what other can it be done like a regular patient without any extension line or any just attach the whole thing to the
No,
IV
sir.
cannula?
The surgeon will be occupying the head, and so we need extensions and everything. And
So both
from
sides
the
the surgeons
head,
will be standing. One side the operating surgeon, the other side will be the nurse and the assistants. So, but the first and foremost important practical point you have to remember in thyroid surgery is to have a good IV access. So that will be, even if you start an IV cannula in the dorsum of the hand, you have to have a 100 centimeters extension line. What are all the various sizes of three-way extension you know? What is the smallest size? What is the largest size?
just only the 3-way is there, sir, and 10 centimeters there, 100 centimeter and 200 centimeters there, sir.
You have 25, you have 50, you have 100, you have 50. Okay. So
Okay, sir.
even smaller than 100 you have 25 and 50 are also available. Okay. So
Yes.
ideal to have a 100 centimeter three-way extension so that you will have a good access. Supposing it is not available in the theater, you don't even have a 10 centimeter extension. So what will you do?
Secure IV
Because
line in the lower limbs, sir.
in the lower dorsum of the foot. Good. So that is the other option. Okay, dorsum or the at the ankle level, you can always cannulate the veins in the lower limb. So if you don't have an extension, that is the next option. Okay. Where will you keep all the monitors? Head end or foot end?
Foot end would be better, sir.
Foot end will be ideal. Okay. What is, how do you know, supposing patient has got subclinical hyperthyroidism, and they develop a complication called thyroid storm. What is the first earliest indication for the onset of thyroid storm?
So there would be sudden rise in the ETCO2.
Very good. Then,
Tachycardia would be there.
very good.
The patient will be the patient will develop fever that had hypothermia.
Very good. So what are the important monitors you should keep for a patient with who has been suffering from thyrotoxicosis and then treated and coming for surgery?
We have to monitor temperature, sir. Temperature
Temperature.
monitoring.
So what are the precautions you will take if a patient post thyrotoxicosis treated and made euthyroid comes for surgery to prevent or treat thyrotoxicosis that can suddenly happen? What are the, how will you prepare yourself or equip yourself?
To ensure that the patient is taking beta blockers.
Okay. Is beta
Then
blocker very important or anti-thyroid drugs are very important?
anti-thyroid drug has to be taken on the day of surgery.
What are
Also,
the
sir.
anti-thyroid drugs that you know?
Propyl thiouracil,
Hmm.
carbimazole, metimazole, sir.
Okay. How do they act?
Um, it inhibits thyroid peroxidase enzyme, sir, so that there would be no formation of
Synthesis itself
thyroid
is
antibody.
reduced, isn't it?
Yes, sir.
So anti-thyroid means the formation of T3 and T4 are inhibited by these drugs. because the enzyme that is required for this conversion is inhibited. So the production of T3 and T4 itself is inhibited. Which is more active, T3 or T4?
T3 is more active, sir.
More active. So even if you have a large amount of T4 produced, it has to be converted to T3. Which drug will prevent the conversion of T4 to active T3?
Propyl thiouracil, sir.
Propyl thiouracil, that could be that. That
It's
is also acting at the formation level.
Propranolol.
Propranolol, yes, beta blocker is the one which is going to prevent the conversion. Another drug, any other drug apart from propranolol?
So is it Lugolcidine, sir?
Glucosidine helps in the iodine trapping. Iodine, which is the important element for formation. That is
Yes, small
absorption.
also.
Huh? Dexamethasone. Dexamethasone is another drug which decreases the conversion of T4 to active T3. So two drugs, propranolol and dexamethasone, both help in preventing the conversion of T4 to T3 in thyroid storm. Okay. So we have to keep these emergency drugs ready. So how do you prevent or treat the hyperpyrexia, thyroid storm? What are the methods of reducing the patient's body temperature?
uh,
Supposing you would identify thyroid storm on the table, surgeon is operating, you find the ETCO2 going up, you find tachycardia, you find patient's temperature is going up, you suspect thyroid storm to happen. What is the first thing you will do? You should ask the surgeon to stop, okay, and convey to him that you are suspecting thyroid storm and you are going to take steps to control that. So further more stimulation of the gland will worsen the condition. So first and foremost thing is to stop surgery and then start the supportive measures. So the methods of cooling the patient when they develop hyperpyrexia are either cooling the intravenous fluids, just like keeping the patient warm, you give the warm saline, warming the fluids. Here you do the opposite, you cool the saline, you apply surface application of cooling blankets or ice packs on the main vessels like groin, axilla, etc. And also make the ambient temperature much cooler. Increase the AC, bring it to 16 or 14 degrees. And you can instill cold milk in the stomach through Rayleigh tube or irrigate the bladder with cold saline. So these are all the methods of decreasing the hyperpyrexia. What other drugs you can give to salvage the situation apart from beta blocker and dexamethasone? What other drugs are to be given during thyroid crisis? You give a dose of antithyroid drugs like carbamazepine. How is it given? Parenterally or enterally?
enterally it is given, sir.
You have to put an nasogastric tube and you can give the drug enterally. Okay.
Yes, sir.
What will the ABG show if the patient develops thyroid storm?
Might be acidosis.
It will show severe metabolic acidosis. Okay. So because of the increase in the metabolic rate, it is not matched by the supplies, so patient will go in for severe metabolic acidosis. So ABG should be monitored and the correction should be done according to the pH values. So these are all the emergency methods that you have to do for managing thyroid storm. Right. Luckily, nothing has happened. Surgery has gone through very well. At the end of surgery, you extubate the patient. There is no cuff leak test is normal, there is a leak available, so you have extubated. But patient says they have difficulty in breathing. What could be the cause?
A nerve injury, sir. Recurrent
Nerve
laryngeal
injury.
nerve.
Okay. Which nerve will get injured?
Recurrent laryngeal nerve.
Recurrent laryngeal nerve. So which is the most dangerous recurrent laryngeal nerve injury?
Sir. Bilateral partial recurrent laryngeal.
Bilateral partial. Very good. Last class we discussed, whenever we talked about the recurrent laryngeal nerve injuries, we talked about larynx. The class we stopped. Okay. So partial, bilateral, partial recurrent nerve injury is the dangerous intermediate manner. Other types are all very gradual. And other reason for immediate difficulty in breathing, apart from the nerve injury?
Hematoma.
Supposing nerve injury is not happened, vocal cords are moving normally. What could be the other causes for difficulty in breathing after extubation? Surgery has taken a long time, 4 or 5 hours they have operated. Very slow surgeon. They've been going on meddling with the trachea and trying to operate.
The edema will be laryngeal
Edema. Yes, you can get a severe edema. Epilotic edema can happen in adults, and tracheomalacia, of course. Even without a positive leak test, you can get tracheomalacia sometimes in the long-standing cases. Supposing patient develops respiratory difficulty after 4 hours from the post-op ICU, you get a call that patient is having difficulty in breathing and the neck swelling is increasing. What could be the cause?
Hematoma would be there.
It is a hematoma. So what will you do in that case? So you rush to the PACU, you find patient is distressed, saturation is low, there is a huge swelling in the front of the neck.
We need to immediately decompress that swelling, sir. We need to open those sutures, release the hematoma.
Hematoma, very good. And increase, supposing patient has been receiving very low flow oxygen, first increase the oxygen to high flow oxygen and even try to help with a CPAP and try to instill more oxygen into that and relieve the compression as quickly as possible. Supposing after 24 hours of the surgery, patient complains of stridor and difficulty in breathing, what would be the cause? First post-op day. And it was a total thyroidectomy surgery. Very late complication. Hypocalcemia, okay, tetany. Parathyroid also could have been removed. Okay? That leads to hypocalcemia. So how will you prove that it is hypocalcemic stridor and difficulty in breathing? What the clinical test can confirm hypocalcemia?
A patient may complain of peripheral and perioral numbness, sir.
Numbness, very good. Then
we can see we can tie a BP cuff over the arm and inflate it for 2 or 3 minutes, and the patient will develop carpopedal spasms, Trocheus sign.
Trocheus sign, okay.
And tapping the facial nerve can also produce facial muscle, Chevstock sign, sir.
Chevstock sign. So the subjective and objective methods of proving hypocalcemia. Patients complain perioral numbness and tingling, stridor. Objective is Trocheus sign and Chevstock sign. Okay, that is how you should answer in the examination. So these are the 3 stages where respiratory difficulty can happen in the patient after surgery. It is called immediate, intermediate, and late. Immediate is either nerve injury, edema, or tracheomalacia. Intermediate is hematoma, and late is hypocalcemia. Okay, so these are the points that you have to remember. I'll just show you the list of all these things. So here is the so instead of this old case scenario I gave, it's a 55 older patient, not a younger patient like this. The features of compression are there. So from the history, you have to get all this information like duration of swelling, duration of difficulty in swallowing, any difficulty in sleeping back, how the patient adapted to that difficulty. So usually patient will turn to their lateral side, either right or left when they have difficulty in breathing through lying on the back. So that history will be very important to assess the compression features. And whether the patient notice the swelling moving with deceleration, whether the patient notice any change in the eye, and all features of hyper or hypoactivity of thyroid have to be, you have to get that information. Then examination of the swelling by inspection, palpation, percussion, and auscultation, both from front as well as from the back. That is a very important point you have to say in the practical examination. So you have to palpate it from the back with the 4 fingers from behind, and in the front you can adjust the midline nature of the swelling by putting your 2 fingers on the suprasternal, the sternoclavicular joint, and trying to use your middle finger to insert it between the gland and the sternocleidomastoid to find out whether there is a deviation to the inside. And consistency, retrosternal extension by percussion over the manubrium sterni, auscultating from buoy, and what are the indications for surgery? Why the surgeon wants to do the surgery? Is it for cosmetic purpose, or is it for pressure symptoms, or is it for uncontrolled hyperthyroidism, not amenable to treatment, and or is it a malignancy which is infiltrating? So the indications for surgery also we should know. And then the anesthetic management, make sure that all patients with elective procedures are operated in a euthyroid state. Whether if they are hyperthyroid, they should receive anti-thyroid drugs and continued on to the date of surgery. If they are hypothyroid, that should also be corrected with supplementation of thyroxine. And difficult airway assessment should be done. Free of calcium assessment is very, very important to rule out any chances of hypocalcemia that is happening, because sometimes pre-operative itself the calcium may be low. So we have to include calcium for all cases as a pre-anesthetic blood test. And plan for management if there is a retrosternal extension for removal by sternotomy or mediastinoscopy. Nowadays, robotic removal of thyroid also is being done, approaches through oral or other areas. So that also may be asked in the scenario. Intraoperative management, IV access, where it should be placed peripherally as far as possible from the operating field and the surgeons, with a 3-way extension of sufficient length. Patient positioning, the supine position with the neck extension. Eye should be protected, and pressure point should be protected with adequate padding. And you can use a flexometallic tucked oral tube with a lightweight breathing circuit to prevent dragging on the tube because of this position. And dilute adrenaline infiltration sometimes may be required by the surgeon. They may ask you. So if it is a case of treated thyrotoxicosis, I would advise you to prevent the surgeon or desist the surgeon from infiltrating with any adrenaline containing solution. On the contrary, a euthyroid patient, you can ask them to go ahead and do that. So supposing surgeon asks you, madam, how much of adrenaline should I add? What concentration should I use? What will be your advice? What is the safest dilution of adrenaline that can be used for hemostatic purpose at the operative site without systemic effects of adrenaline. How much of adrenaline is there in 1 ampule of adrenaline? Hello? Are you all there?
Yes, sir. Generally, in a 1 ampule of adrenaline, we give in 200 ml of water approximately.
Now, how much of adrenaline is there in 1 ml? That 1 ampule. It is 1 milligram, which is 1000 micrograms. Okay, that is why it is called 1 in 1000 adrenaline. So 1 ml contains 1 milligram, which is 1000 micrograms. 1 milligram of any drug is 1000 micrograms. So if you add this to 200 ml of saline, then each ml will contain 5 micrograms. That is the safest solution. That is called the 1 in 200,000 dilution. So 1000 parts you dilute it to 200 ml. So it make it into 200,000 dilution. So each ml will contain 5 microgram, and you can use 5 microgram per kg body weight. This and 1 ml you can use for 1 kg body weight. So if the patient is 70 kg, you can use up to 70 ml of this diluted solution. That is the calculation that you have to tell. Okay, so that is the dilution. Sometimes hypotensive anesthesia may be required for vascular thyroid cases, and nowadays they use the recurrent laryngeal nerve stimulation intraoperatively to make sure that there is no damage done to the recurrent laryngeal nerve, for which nowadays we have special types of endotracheal tube through which they can stimulate that. So if that neuromonitoring is planned, how will your anesthetic management change according to that?
Muscle relaxant to be
You have
avoided.
to avoid two things: muscle relaxant and which other anesthetic agent will inhibit the stimulation of the nerve and its response. Volatile anesthetic agents. Okay, so you have to go in for what is called TIVA technique. Of using controlled ventilation with muscle relaxant and maintaining anesthetic plane with volatile anesthetic agent like sevoflurane, isoflurane, or desflurane. You have to avoid both. You cannot use atracurium, citracurium, or veteronium, and you cannot use CO or ISO or dexo. So you have to go for what is called total intravenous anesthesia technique using remifentanil or propofol combination, or dexmedetomidine and propofol combination. So many combinations are available. So with that only you have to maintain the plane of anesthesia and ventilate with oxygen and air without any other volatile agents. And by this intravenous agents itself, you have to slightly hyperventilate and make the patient go in for some sort of controlled ventilation. And at the time, whenever the surgeon stimulates, patient will automatically respond because there is no neuromuscular blockade or volatile agent. So that is the preparation that you have to know. The current scenario of need for neuromonitoring of recurrent laryngeal nerve. Now, these are all the important intra-anesthetic intraoperative management. So, patients who have already had thyrotoxicosis, you have to have all the preparations for managing a thyroid storm. Similarly, patients who are hypothyroid, most of them do not give you any problem unless they are very poorly controlled hypothyroid patients. Mild hypothyroidism is not a great contraindication. But what precautions you will exercise if the patient is a hypothyroid patient and is on a heavy dose of thyroxine supplementation, like say 100 micrograms or 150 micrograms per day. TSH is somewhere around 15 or 20 like that. T3, T4 are normal, but they require heavy doses of thyroxine. In that situation, what will you do? what are the precautions you will take for hypothyroid, just like your thyrotoxicosis, what preparations or what drugs you have to keep ready for, what is the complication they can develop. Opposite to thyrotoxicosis, what is the complication for hypothyroid patient?
Myxedema coma, Devam.
Myxedema coma, good. So how do you prevent that? For the drugs, we have to be cautious in usage.
Sedatives,
Narcotics. They are very sensitive to narcotics. They don't have the hypercarbic response to respiratory stimulation will not be there in sedation. Okay, so you have to be very careful in usage of narcotics. What is the next important thing that you have to keep in mind? Which other ambience or the body condition which can precipitate a myxedema coma?
we have to keep the patient warm, sir.
Temperature. So patients, they become hypothermic very fast. Just like a thyrotoxicosis patient developing hyperthermia, hypothyroid patients become hypothermic much more faster. So hypothermia, once they core body temperature goes to below 35 degrees centigrade, they will not respond. They will not recover. So you have to maintain their warmth body temperature. Just like opposite to thyrotoxicosis, you have to keep the ambient temperature more higher. You have to keep the patient's body covered with warming blankets. You have to give warmed IV fluids instead of cold. So whatever you do for thyrotoxicosis, you have to do opposite to maintain temperature. So if you take care of these two things, narcotic control or avoiding as much as possible the narcotics and maintaining the body warmth, then you can easily manage any hypothyroid patient without problem. Okay. Then post-op management, extubated awake with head up tilt, airway obstruction, immediate due to edema, recurrent lung injury or tracheomalacia, and intermediate bleeding and compression. Late complication is hypocalcemia. And what are the other things you have to learn with regard to thyroid is anatomy of thyroid gland. They may ask you the location, the size and everything, the lobes, and the physiology of thyroid hormone synthesis and control, their mechanism of action, positions of examination for thyroid gland, eye signs, the names and the various description, drugs used for treatment of both hyper and hypothyroidism, Lugol's indication, what is Wolff-Chaikoff effect, thyroid crisis and myxedema coma features and management, types of recurrent laryngeal nerve palsy, regional blocks for thyroid surgery, like superficial and deep cervical plexus block. So these are all the points that you have to keep in mind for. So this is a gist of how to deal with practical exam, viva exam of a thyroid case. Okay. Prepare for that, you will be able to manage the situation. Okay. Any doubts on